It's late in the afternoon, it's nice outside, so I'm not going to belabor this, and I'm going to hit some key points as part of this particular subject and highlight what you should walk away with in this particular talk. And it's a pleasure to be here, and I want to thank Garota and certainly the faculty at the Brigham for putting on the course. So here are my disclosures. Okay, I decided that we were going to talk about cases, and in it we are going to, I should say, highlight key concepts that come up. So you're seeing a 28-year-old woman with chronic kidney disease stage 1, and she's 12 weeks pregnant. Everyone remembers the standard changes that happen in pregnancy, and the key points that you should recall, of course, is that serum creatinine goes down primarily because the GFR goes up. GFR goes up 50 to 80%. The peak of GFR is about the second trimester. And so if you see a woman in the second trimester with a serum creatinine who started off with a normal serum creatinine, but who has a serum creatinine in the second trimester of 1.2, that is distinctly abnormal. Why? Because the normal creatinine in the second trimester, for example, should be 0.7, 0.6, 0.5, somewhere thereabouts. So this always it comes up, which is what's a normal creatinine in pregnancy? Again, peak GFR second trimester, and it should be 0.5, 0.7, 0.8, somewhere thereabouts. Urine protein goes up in pregnancy. I often get called by nephrologists and non-nephrologists to say that I have a woman who is completely fine. She's, let's say, 25 weeks of she's at 25 weeks of gestation, and she has 6 grams of protein. And so the first question I always ask is, does she have underlying kidney disease, and did it antedate pregnancy? And if the answer is yes, it is not uncommon for somebody to have proteinuria before pregnancy, and as a result of the increase in GFR, proteinuria goes up. And sometimes it goes to several grams, and hence it makes it difficult to make the diagnosis, for example, of preeclampsia, which is an increase in proteinuria. But proteinuria can increase just because the GFR goes up without worsening, if you will, of kidney function. So just to remind ourselves, in this particular patient, stage 1 kidney disease, the definition of stage 1 kidney disease, I used to not think this was an entity. However, I'll show you some data to argue why it is an entity. But just the first question I have here, I don't know if do you have questions, or I'm just going to show the answers? Yep, okay, great. So the definition of stage 1 kidney disease, certainly we're all familiar with. And what constitutes that definition? Obviously A, C, and D. But here are some key points that come up, which is albuminuria in the context of chronic kidney disease. And people have argued, of course, that we need to define chronic kidney disease not just in the context of GFR, structural abnormalities, and so forth, but of course in the context of albuminuria. The reason I like this is because at conception, the presence of albuminuria actually has a very strong predictive outcome for the fetus. It doesn't actually, interestingly enough, predict the risk of preeclampsia, but it has a very strong predictive value, if you will, for the outcome of the fetus. A woman at conception, for example, with chronic hypertension, who has proteinuria, again, at conception, has a much worse outcome for her fetus, or a higher risk for a worse outcome for the fetus, namely fetal demise, just by having albuminuria at conception. And so I think the combination of GFR and obviously the other categories of CKD, but the albuminuria plays an absolutely key role. We're often asked, how do you estimate kidney function in pregnancy? And we've written a number of chapters and articles on this particular topic. And the point being is, it's difficult to implement a number of these equations that we typically use, whether it be CKD-EPI or MDRD and so forth. And what I end up essentially saying is, look at the serum creatinine and essentially follow that. Now, of course, if you want to translate that to a measure of GFR, you can do so. But the serum creatinine in general is pretty good. The 24-hour collections are often, as we remember, under or over collection, and so we have to be careful. The other thing to remember in pregnancy, the obstetricians are most often interested in protein creatinine ratio and not albumin creatinine ratio, and it turns out it has a better predictive value for preeclampsia, which is an adverse outcome of pregnancy that many of you are familiar with, and albumin creatinine ratio. So you'll often see PC ratio as opposed to albumin creatinine ratio. So let's talk about chronic hypertension, which is commonly seen in young women. Certainly now, given all the risk factors that we have to think about, which one of these statements is incorrect regarding adverse outcomes of pregnancy? So the issue is here is you have a woman with chronic hypertension, she gets pregnant. What are the incorrect statements here? So it turns out women with chronic hypertension, almost in every study to date, show that they have a 25% increased risk of preeclampsia. They have no change in their risk of getting better, if you will, if you actually treat them aggressively. That is to say, there have been multiple randomized trials showing that you can treat blood pressure aggressively, but you actually don't change the outcome or if you will, the risk of preeclampsia. So the incorrect statement here is low risk of adverse outcomes, even if managed well. And that primarily comes from the following studies, which I'll get to in just a second. This is just to highlight this risk of chronic hypertension and preeclampsia. And interestingly enough, when you look at some of the classic papers on women with chronic hypertension and risk for preeclampsia, at conception or a history of preeclampsia increases a risk of having preeclampsia in the pregnancy. Poorly controlled blood pressure before pregnancy increases the risk of preeclampsia. But interestingly enough, proteinuria does not. But what proteinuria does, as I mentioned, is it really portends the adverse outcome in the fetus. And this is the figure I was looking for, which is at conception, the combination of elevated diastolic blood pressure and elevated proteinuria synergistically predicts fetal mortality. Not adverse outcomes for the fetus, meaning preterm, although it does that as well, but so bad as, if you will, fetal mortality. So there's something about the conceptual milieu of proteinuria that portends this adverse outcome, especially in poorly controlled hypertension. So this is the other point I wanted to make, which is controlling blood pressure during pregnancy in a woman with chronic hypertension. And the key thing to remember, again, as I mentioned even with the previous slide, is that really controlling blood pressure in pregnancy doesn't change the risk of preeclampsia. What it does do, and what trials have shown, is they actually change the risk for severe hypertension. And this is the trial I mentioned earlier, which is the trial that came out last year. And the trial was actually pretty straightforward. It said, let's take women with chronic hypertension or who develop gestational hypertension, that is new hypertension in pregnancy. Let's randomize them to tight control versus less tight control of blood pressure. Now, why was this trial done? This trial was done because we worried historically that aggressive control of blood pressure increases the risk of fetal blood flow compromise, increases the risk for growth restriction in the fetus. So if we lower the blood pressure, we lower the blood flow to the placenta, and as a result, there is an adverse outcome for the fetus. So there's always this controversy, what's the appropriate blood pressure control? So this trial essentially said, let's do tight control versus less tight control. Now, interestingly enough, tight control was a diastolic blood pressure, or I should say a mean arterial pressure. They looked at diastolic, they looked at systolic, and then of course they looked at mean. But the point I want to make is in any of those parameters, there was only about an 8 to 10 millimeter difference. And so in general, the blood pressures for women that were less tight control were 140/90. In general, the women that were more tight control were 132 or so over 80. So it wasn't really that big of a difference. And what they showed by that tight versus less tight control is really no difference in any of the primary outcomes, which were fetal death, including adverse outcomes like preeclampsia and so forth. Absolutely no difference. So there's a debate in the obstetrical and nephrology community, which is how tight should you control blood pressure, because you don't change the outcome for these women. But what they argued in this trial is you reduce the risk of what's called severe hypertension. So this gets to the point from a nephrology perspective, why do we control blood pressure in pregnancy? We do so because we want to reduce the risk of the standard things like hypertensive crisis and so forth, stroke, for example. We don't do so because we want to reduce the risk of preeclampsia. There is absolutely no effect on the risk of preeclampsia. So the argument is you can control it, bring the blood pressures of a woman with chronic hypertension or gestational hypertension to about 130/80 or thereabouts, and you then will have a lower risk of some of those severe hypertensive emergencies. By the way, in this trial, they didn't have any. They just argued that that would be the case. So I usually target 130/80. And of course, some women I go a little bit higher, especially if they've had very long chronic hypertension. So the other point I want to make in the first part of this talk is the stage 1 chronic kidney disease. As I used to say, is it really a disease? And many of us sort of grew up in this era of staging kidney disease, and there's been debates as to how do we actually stage kidney disease. But what's happened in pregnancy, interestingly enough, is that we clearly went through the literature of women with chronic kidney disease, stage 3, 4, and knew and found through many different studies that they have adverse outcomes. And so what then investigators did, including ourselves, is we went upstream and we said, does any evidence of kidney disease, however we categorize that, most often stage 1 or stage 2, increase the risk of adverse outcomes? And that's where the new literature is. I would say just literally in the last 2 years, and I'm actually going to show you some data that we just had from the Mass General that would argue the case. So the answer to this question is stage 1 chronic kidney disease is a risk factor for all of these things, and there's good data to support them now, but it does not portend a further decline in GFR after pregnancy. So if you look at all of these articles, and you look at the underlying kidney diseases, IgA, PKD, as you heard about, diabetic nephropathy. Stage 1 chronic kidney disease, however it's defined, has an increased risk for requiring a cesarean section, preterm delivery, IUGR, neonatal ICU care admission, and preeclampsia. Now again, we remind ourselves that stage 3 and 4 has been well studied, but what we're seeing is even the earlier stages of kidney disease have an adverse outcome. This is actually not a great question, and I just go to this point, which is you have a woman with diabetes, underlying chronic kidney disease, and diabetic nephropathy. And the point I wanted to make in this slide is we often focus on the kidney, but it turns out that retinopathy progresses probably faster than nephropathy. And you can't forget, of course, the eyes in women with diabetes. So what about the stage 1 chronic kidney disease issue? So here's an example of how this now manifests itself. So what are the recommendations for young women who are kidney donors wanting to be pregnant? So these are studies where women, completely healthy, decided to donate one of their kidneys, often to a family member, and then subsequently became pregnant. And what are their outcomes? And you can argue that normal GFR, no hypertension, no diabetes, you can put them in this sort of category of stage 1 chronic kidney disease. And so here, interestingly enough, almost every study that's been looked at, including the ones from Europe, United States, and in fact even some recent data from South America, would argue this is what we see. When you look at those women that have donated a kidney with completely normal kidney function and ask what is their risk for fetal loss, gestational diabetes, gestational hypertension, and preeclampsia, the rates for all of these outcomes are higher than the background rate. And this is from pretty large, relatively large studies in this particular space, 40 years, for example, from a Midwest transplant group looking at 230, 240 post-donation pregnancies, and finding, surprisingly, that those pregnancy outcomes, not the decline in renal function afterwards, that's very separate, and that has to do with severity of chronic kidney disease, but just having some evidence of kidney disease for some reason increases the risk for these outcomes. The most recent study on this post-donation part came in the New England Journal last year by Amit Garg and his group. And what they showed was, again, women that had donated a kidney, 131, compared to non-donors, matched for a number of categories, had, although there's a small number here, but there was an increased risk, for example, for gestational hypertension, preeclampsia, preterm birth, and so forth, so forth. So that's what we're finding. We're finding that there's something about a communication between the placenta and the kidney, and any evidence of kidney disease seems to increase the risk. So again, one more point on this sort of stage 1. Here's another example. Does a past history of acute kidney injury change your pregnancy prognosis? And I used to say, of course not. If you take a woman that has had AKI, let's say from a UTI or something 2 years before, and she comes into pregnancy with a creatinine of 0.6, 0.7, 0.8, completely normal, no proteinuria, no hypertension, how does she do in pregnancy? And what we found at the Mass General, we looked at 25,000 pregnancies, is that those women that come into pregnancy with a past history of AKI, again, completely normal creatinines, right, have an increased risk of preeclampsia, have an increased risk of cesarean section, preterm delivery, abnormal fetal outcomes, neonatal ICU care stay. Again, you would never even consider this a risk factor because she comes to pregnancy with normal blood pressure, no diabetes, no lupus, normal creatinine, no proteinuria. But yet something about her past history of AKI, and again, we just did this study, portends an adverse outcome during pregnancy. Again, pretty big surprise. So that's sort of stage 1. And again, a history of AKI, being a kidney donor, of course, receiving a transplanted kidney turns out to have the same adverse outcomes in pregnancy as well, chronic hypertension. Again, we're becoming much more attuned to this underlying relationship between the kidney and the placenta, and somehow some crosstalk, if you will, that argues that even if otherwise things look fine, the nephrologist needs to pay attention, if you will, to this history, if you will, of these stage 1 kidney disease and why, for example, a woman is in that category. Okay, here's another patient, 32-year-old woman with new AKI, 1.5 grams of proteinuria, 2 weeks postpartum. So now we're going to move the needle after pregnancy, not during pregnancy, and ask what are those etiologies that surround sort of the peripartum period and are associated with AKI. So the first thing often comes up in pregnancy, the most common cause of new onset nephrotic range proteinuria is preeclampsia. It is the most common cause of nephrotic range proteinuria in young women worldwide, no matter how you look at it. And of course, in nephrology, we think all of these conditions are common. Well, relatively speaking, they're much less common than, for example, preeclampsia. In the United States, women the frequency of preeclampsia is about 200,000 to 300,000 women per year. That's just in the US, and of course you can double that or 1.5 times that amount in Europe and so forth. Okay, what is one possible cause of proteinuria postpartum? So you're seeing a woman postpartum, she just had delivery a few months ago. What are we taught in terms of persistent proteinuria? Now, of course, if she had preeclampsia, you might say that I'm willing to accept some proteinuria and not do a kidney biopsy and assume that this is just residual of that preeclampsia, and we're often taught that we should wait for 3 months before we consider underlying intrinsic renal disease. That's usually the thinking, if you will. And it's really this 3-month period that I want to touch on because when you look at women postpartum, we're often told that we can do a kidney biopsy if it just lasts too long. She comes back 6 months later, she'd do a kidney biopsy. She comes back 9 months later and she still has proteinuria, she'd do a kidney biopsy. When should proteinuria disappear postpartum is really the key question. And as I said, most often we're told 3 to 6 months, certainly 6 months, but clearly by 3 months we're starting to get worried. And the most recent literature would argue the following. That is, the more severe the proteinuria in pregnancy, whether there was preeclampsia or not, the longer it takes to resolve itself. The more severe the hypertension is in pregnancy, no matter related to preeclampsia or not, the longer it takes to resolve itself. And this is on top blood pressure, this is proteinuria, and on time this is weeks, going out to longer than a year and a half, if you will. And sometimes it just lasts, and it's not because there's underlying kidney disease. It's because there was such severe hypertension or proteinuria, and it takes time to resolve itself. Now, frankly speaking, I've biopsied women at 6 months, 5 months, 12 months, worried about this. And we have to remind ourselves that sometimes it takes time. And obviously in those circumstances, I've also uncovered new onset kidney disease, which we need to be careful about. But it is not and should not be a surprise if there is persistent proteinuria or hypertension. Okay. One of the most common conditions we deal with in pregnancy, especially in young women, is diabetes and lupus, and I'll just spend a few minutes, if you will, on each one of them. Women with diabetes, in the absence of diabetic nephropathy, do fine in pregnancy. They have good fetal outcomes, they have good outcomes, they don't accelerate their kidney disease. It's when you have diabetic nephropathy, proteinuria, that you begin to get into this category of adverse outcomes. So this is a woman, 32 years old, 2 weeks postpartum, 1.5 grams of proteinuria. If she had diabetic nephropathy and 300 milligrams of protein per 24 hours pre-pregnancy, then what should we expect? And the answer here is we should expect proteinuria to increase in pregnancy, and 1.5 grams postpartum is not uncommon. This is a very classic consult where a woman has pre-existing proteinuria with diabetes. It gets worse in pregnancy, and we just told you the proteinuria itself portends an adverse outcome for the fetus. But it may not be getting worse because of preeclampsia. It's just the GFR goes up and proteinuria gets pretty heavy, and it can get quite heavy. And as I told you, the more heavy it gets in pregnancy, the longer it lasts postpartum. So in the chapter that we wrote in Brenner's textbook, we categorized gestational diabetes, diabetic nephropathy, diabetes with normal albumin, microalbumin, and so forth. And the point I want to make with this slide, and this is the categorizations of diabetes, if you will, this is the abnormalities, whether it be GFR, proteinuria. The point is that anytime there's underlying renal disease, even microalbuminuria, there is an increased risk of preeclampsia. For some reason, women with diabetes have an increased risk of preeclampsia, a risk that is 2 to 3 times increase the risk for otherwise normal women. So if it's 5%, we're talking 15 to 20% risk. And especially in women with evidence of diabetic nephropathy, but even in women with microalbuminuria, have an increased risk, for example, of preeclampsia. So that's diabetes. What about all those other chronic kidney diseases? Well, the classic studies come from Jones and Heiselett in the New England Journal a few years ago, or I should say many years ago now. But the largest series is one that we continue to follow, and there's been certainly studies since then looking at GFR, but this is why I like the creatinine, only because it's simple, it's straightforward, and there's a cutoff. We don't have to worry about fancy calculations, so to speak. And here in general, when creatinine goes above 1.3, 1.4, there seems to be an adverse outcome. When it's less than that, no matter what the underlying kidney disease is. We used to say that women with FSGS do worse than women with MPGN. We used to say women with lupus do worse than women with diabetes. And the answer is it doesn't really matter. It is the serum creatinine, or more importantly, the kidney function, that really portends the adverse outcome. The higher the serum creatinine when you're pregnant, or at least when you are at conception, the more likely that you will progress postpartum, the more likely that you'll require dialysis. And as I mentioned, obviously the fetal outcomes are just as bad when the serum creatinine goes up. So which diagnosis is least likely? And of course, I'm showing you this because this was the case I presented. And let me just remind you, this was the woman who had 1.5 grams of proteinuria 2 weeks after pregnancy. So think about postpartum proteinuria, postpartum increased renal, or more, if you will, renal dysfunction. Is this new onset glomerulonephritis? Is it pre-existing IgA or SLE, new onset atypical aHUS, or postpartum preeclampsia? And so the point I'm trying to make here is that postpartum preeclampsia is not something that happens 2 weeks postpartum. I often get, not often, but I will get consulted in somebody who has hypertension and proteinuria at the time of delivery. That could be preeclampsia. But once you start getting 3-4 days after that, it is pretty uncommon to having preeclampsia be the etiology. Now, people have looked at acute kidney injury in pregnancy, which is something we might get consulted for, and acute kidney injury is in the category of preeclampsia. And the largest series comes from this study in India. And there are a lot of etiologies, but sepsis, retained products of conception, pregnancy-induced hypertension are some of the most common causes, if you will, of AKI during pregnancy. But this particular figure is one just to keep in mind. So this is gestational age on the top, this is postpartum, and this is when you see the different etiologies. You might get consulted, right? So if you think about the arrow here, which is delivery, these are the etiologies you see of acute kidney injury postpartum, TMA, atypical aHUS. Preeclampsia is not seen early in pregnancy. So if you're consulted at 15 weeks of gestation for somebody with proteinuria, it is typically not preeclampsia. Preeclampsia is something that happens after 20 or so weeks of gestation. But interestingly enough, you can see atypical aHUS here. But often is the case, first of all, AKI in pregnancy is uncommon in general. But if you are consulted for it, you're consulted for it in this time period. Why? Because all those conditions that lead to AKI in pregnancy are heavily concentrated at the 24 to 40 weeks. Abruption of the placenta, hemorrhage, sepsis, preeclampsia, aHUS, TTP. Very difficult to diagnose these things. How can you diagnose some of them? Well, time. Postpartum, it's unlikely to be, of course, hemorrhage, peri-partum. It's unlikely to be preeclampsia. It's more likely to be aHUS, TTP. Very early in pregnancy, unlikely to be preeclampsia, more likely to be intrinsic renal disease. So that's really your benchmark in terms of trying to understand what test would you order. The point I was trying to make with this is a postpartum women, 2 weeks, proteinuria, elevated elevated serum creatinine, and a platelet count. And the question is, why do you get a low platelet count in pregnancy? And you can do the standard workup. But the point I was trying to make here is when you see postpartum acute kidney injury, the first thing you should think of, other than preeclampsia, which happens at the time of delivery or shortly thereafter, you should begin to think of atypical aHUS and schistocytes. Now, you might say, well, we have a lot of laboratory tests that can help us distinguish HUS and TTP from HELP, which is another manifestation of preeclampsia, from acute fatty liver pregnancy. Let's say, for example, you're seeing a woman at 39 weeks of gestation, she hasn't delivered, and she has elevated serum creatinine and proteinuria, and you might say, well, here's my differential, and I can use a number of these lab tests to help decide what the etiology is. And so I will get called and somebody will say, there are schistocytes on the smear. Can you see schistocytes in preeclampsia? Absolutely, right? Can you see elevated LDH in preeclampsia? Absolutely, even though classically we're taught that that's sort of atypical HUS. The point of this slide is to say that it's very difficult to make the diagnosis on those standard clinical parameters that we typically use. Now, we're all familiar with the thrombotic microangiopathy, and you'll certainly hear more about this during the course. And I'm not going to belabor it except to say that the manifestations are protean and they're severe and they can affect many different organ systems. But a common question on the boards, a common time we get consulted for acute kidney injury, if you will, in pregnancy is atypical HUS. And the biopsies look exactly the same. They look like what you would otherwise see, the fibrin deposition and the thick membranes, the microthrombi in the kidney. And there's been a lot of literature on atypical HUS, of course, in the field of etiologies and diagnosis, which I'm not going to review. Should you get one test versus another? And I just want to highlight a schema or a schematic diagram that I put together based on how pregnancy fits into this schematic diagram. So the point here is you're seeing a woman with thrombocytopenia, anemia, and renal failure, peri-partum, okay? And of course, we have to rule out the typical HUS etiologies, namely infection. And if that's not the case, you get an ADAM-TS13, and that's fine. And if that, of course, is low, or there's a function abnormality of ADAM-TS13, that's in the TTP category. But if the answer is the ADAM-TS13 is fine, then it's in this atypical HUS category, and this is where pregnancy in a young woman, or a woman, of course, of childbearing age, comes up. An important time when you see atypical HUS in young women are when they're pregnant, or postpartum, or peri-partum. For some reason, there is a trigger with pregnancy to triggering this kind of condition. Now, when we see this condition, we often ask the question, should we treat, and how do we treat these women, which I'll touch on. But it is not uncommon that if you see atypical HUS in pregnancy, that there's an underlying genetic predisposition. And often is the case that when you think of genetic predisposition for atypical HUS, I hate to show this diagram because it reminds me of those, cofactors for coagulation and those things we learned in medical school. But the point being is there are some common classic hereditary complement disorders that are uncovered in pregnancy, if you will. That is, a woman is completely fine and something about pregnancy uncovers the predisposition. And it's typically seen in this alternate pathway of complement, and it's primarily factor H. Now, there are clearly a number of other genetic abnormalities, but it's typically in this factor H. And the only point I want to make here, and a number of people have written about this, is, I look at the complement system as the following, which is, it is a system that is constitutively active. It is always on, right? And so the brakes to that system and abnormalities in the brakes is what leads to the uncovering or then the disease of atypical HUS. And a major brake in the system is factor H, and factor H happens to be the most common, if you will, genetic abnormality associated with atypical HUS. Obviously, this is an article by Ramuzzi and his colleagues in the New England Journal looking at all those genetic factors. But I typically test for ADAM-TS13 and factor H. Renal cortical necrosis in pregnancy does happen. Now, we don't see it often, and you see it typically more in developing countries, but the etiologies of cortical necrosis with poor flow in the periphery in pregnancy, abortion, HUS, and bleeding, of course, and sepsis, if you will. Septic abortion, hemorrhage, and so forth. But HUS is associated with renal cortical necrosis in pregnancy. So if you see cortical necrosis or you're suspecting cortical necrosis, then think of HUS. And why is it that pregnancy triggers this condition? We don't know. But it comes about, or at least the association in the 1970s of oral contraceptives, if you will, and oral contraceptives and triggering atypical HUS was identified. This is a Lancet paper in 73. In 79, our own people know, of course, Alan Nissen in the dialysis world, wrote on postpartum HUS, again, after pregnancy, seeing aHUS, somehow pregnancy triggering this particular condition. John Heislett wrote about this. And here's a very important point, which is the syndrome of atypical aHUS, postpartum renal failure, if you will. The syndrome is regarded as distinct from renal failure occurring during the third trimester or within 48 hours of pregnancy. If it's within 48 hours of pregnancy, it's typically obstetrical related. It is the bleeding, it is the hemorrhage, the sepsis, eclampsia, embolism, and so forth. When you get further out, 1 week, 2 weeks, you begin to think of atypical aHUS. That's not when these other conditions present itself. And so I have a few questions in here, which is sort of among women of childbearing age with atypical aHUS. So if you take the Venn diagram and say of all women of childbearing age, and these women all have atypical aHUS, 10 but up to 50% of the time they'll do so peri-partum or postpartum or intrapartum. So there's something again about pregnancy that sort of triggers this condition. You do see this in the first trimester, and when you see aHUS in the first trimester, it's typically because of a genetic underlying condition. Factor H, ADAMTS13, or one of the other factors, factor I, or so forth. So think about testing, especially for genetic predisposition for this condition, if you see it in the first trimester. Now, we're excited, of course, about many of the therapies, but I want to remind you that in pregnancy, you can actually do plasma exchange, plasma infusion, and classically, even going back to the 1980s, for TTP-aHUS in pregnancy, treating with plasma exchange was pretty effective. Increase in platelet counts, improvement of hemolysis, reduction of serum creatinine, and so forth. So we reach to, for example, some of the more novel therapies, the expensive ones, of course, but plasma exchange works remarkably well. And how do I know that? How do we know that? Well, many of us grew up reading this paper, the Bell and Rock paper, for example, in the New England Journal in 1991, where they characterized improved survival of TTP and aHUS with plasma exchange, plasma infusion. And we have to remind ourselves, in that classic case series, 9 patients, just under 10%, if you will, were actually peri-partum. It is a common time young women present with atypical aHUS. And these women, of course, went on to have cesarean sections. Offspring were fine when they got treated, so you can treat. We've had patients, and I know the Brigham has had patients where we treat them in the third trimester to extend their pregnancy, let's say from 32 to 36 weeks, so that they can march a little bit further on and mature the baby. So plasma exchange, plasma infusion can be used in pregnancy, and it's not a bad way, if you will, to treat this condition. So then the question is, can you actually use some of these complement inhibitors, factor V inhibitors? These are humanized antibodies, IgG2/4 antibodies. And we used to and continue to worry that these antibodies cross the placenta and may cause complement defects in the fetus. But people have used eculizumab and other, there's no other one at the moment, but complement inhibitors, if you will, intrapartum and postpartum. And the category from the FDA is for eculizumab is category C. And just to remind you, that in animal studies have been shown to have adverse effects on the fetus, but in humans we don't have many studies. But I can tell you there are case series and case reports of using this agent in and around pregnancy, and they seem to be pretty safe. But again, there's no FDA approval in that category. So when you think of thrombocytopenia, anemia, and renal failure, yes, we're taught to think about and go through this pathway, atypical aHUS and in pregnancy. But interestingly enough, as I go back and remind you that preeclampsia can present in the very same way. Preeclampsia can present with thrombocytopenia, anemia, and renal failure. And unfortunately, the only way to tell the difference or sometimes distinguish them is a renal biopsy. But even though renal biopsies actually overlap, and so the timing of when this occurs is important. And then you're left with the decision of do you treat with plasma exchange, plasma infusion, or eculizumab, and if that doesn't get better, you deliver, because delivery is the only treatment for preeclampsia, or do you just take a risk and just deliver, and you do so, of course, if she's close to term, because you don't want to take the chance, and that's really the dilemma. So these are some of the take-home points. Chronic kidney disease stage 1. Don't forget, we know about 3 and 4, but stage 1 associated with adverse outcomes. And that's the new literature, the woman who's donated a kidney, woman with previous history of AKI, okay? Therapies to manage hypertension in pregnancy, reduce the risk of severe hypertension, but more than a dozen randomized trials, including the most recent one, do not change the risk of preeclampsia. The most common cause of nephrotic syndrome in pregnancy, preeclampsia. Postpartum, don't forget, proteinuria can persist. It just depends on the severity of how much proteinuria existed during pregnancy. And don't worry, if you will, if it's at 3 or 4 months, but you see the trend going in the right direction. AKI postpartum is due to hemorrhage, sepsis, preeclampsia, aHUS, TTP, difficult differential diagnosis, but timing, of course, is on your side. And then finally, first-line therapy for atypical aHUS, I would still argue is plasma exchange, but certainly data on eculizumab has shown that it is probably going to be safe, but we don't have an FDA indication. There are a number of resources to use. We did not talk about transplant and dialysis. I think just in the last minute or two, the answer for a woman in pregnancy who's receiving dialysis is more dialysis is better in general, and a lot of studies have shown that, and a lot of the requirements for EPO and iron go up. Transplant, typically we say 1 or 2 years after the transplant is safe, but a woman who's had a transplanted kidney has an increased risk for some of those fetal outcomes as I showed you. There's no perfect time, and then you have to always watch for those medications that are safe in pregnancy. And the last point I'll make, and then I'll end here and I try to get you guys back on time, is the following. We are often told, and it is correct, that ACE inhibitors are contraindicated to use in pregnancy. It's been shown at first trimester, second trimester, third trimester. What people forget is that ACE inhibitors are pretty good medicines to use in breastfeeding. That is, it does not get into breast milk, and the ratio of breast milk to plasma is somewhere like 0.01, 0.02, compared to a atenolol or a calcium channel blocker or even a diuretic where the ratio is 0.2, 0.5, or even 1. So very little ACE inhibitor ARBs get into breast milk. And so people often say, well, I can't use ACE inhibitors. You're absolutely right. You can't use it in pregnancy. But it's okay to put women back on it even if they're breastfeeding because very little gets in. And primarily the studies have been done in captopril and enalapril. So I'll stop there and I'm happy to answer any questions. Thank you.